from Petchprapa, and today I'm here to speak about MR imaging of the shoulder in sports. How many things did we do today that involve the shoulder? We can take it for granted, but the shoulder is capable of doing highly complex movements that are essential for the performance of activities of daily living. But the average human uses only a fraction of the incredible mobility and strength of the shoulder every day. High-level athletes, on the other hand, maximize and even exceed normal physiologic limits in range and strength. They're able to achieve serve speeds, club head speeds, pitching speeds, and bat speeds that exceed 100 miles an hour. And these athletes do this over and over in the course of training for each game or match and for the length of their careers. Athletes in contact sports put their relatively unprotected shoulders at risk for trauma. Shoulder pain is incredibly common, both in serious athletes and in the general population. And the most common causes are related to overuse and trauma. Today, I'll cover MR imaging of the more common sports injuries of the shoulder, overuse injuries of the rotator cuff and surrounding tissues, and traumatic injuries of the glenohumeral and acromioclavicular joint. First, let's image the shoulder. MR is the imaging modality of choice for the evaluation of internal derangement. When properly done, it provides a high-quality, standardized, and comprehensive assessment of shoulder bone, joint, and soft tissue. Coils play a major role in overall image quality, so choose a shoulder coil whenever possible. A shoulder coil places imaging elements close to the shoulder and is configured to provide the best imaging. When a shoulder coil isn't available or doesn't fit the patient, a flexible coil can be placed in a way to conform to the contours of the shoulder. The flex coil is also used for a specialized view called the AREP view. I'll talk in more detail about this later, but the AREP view can be particularly helpful in evaluating the athlete's shoulder in certain circumstances. Position the patient supine on the scan table with the arm in neutral to mild external rotation and the shoulder as close to isocenter as possible. Prescribe the imaging planes off the axial scouts or axial images. Prescribe the coronal oblique plane in line with the supraspinatus muscle tendon unit or scapular spine. The sagittal oblique plane is perpendicular to the coronal oblique plane. In terms of protocol, fluid-sensitive sequences make pathology more conspicuous, so we choose fat-suppressed T2 and fat-suppressed proton density. T1 and proton density sequences are great for showing anatomy, and T1 for the marrow. This is our routine protocol: coronal oblique proton density and fat-suppressed proton density, sagittal oblique fat-suppressed T2 and T1, and axial fat-suppressed proton density. We also do MR arthrography in certain circumstances, which is done after a 1 in 20 dilution of gadolinium is injected into the joint to distend the joint and make labral and rotator cuff pathology more conspicuous. When we use gadolinium, we do fat-suppressed T1 weighted images, and we add an AREP T1 fat-suppressed sequence at the end of the exam. Let's look at the images. Side by side, coronal oblique, proton density sequences, fat-suppressed and non-fat suppressed. This is the front of the shoulder, and we will review the images from front to back. This is the coracoid process, and attached to it are the short head biceps tendon and coracobrachialis muscle. This is the subscapularis muscle and tendon. The subscapularis tendon will be inserting on the lesser tuberosity here. The lesser tuberosity is the medial boundary of the bicipital groove, and here is the biceps tendon within the bicipital groove. We can follow the biceps tendon as it enters into the joint to insert at the supraglenoid tubercle with the superior labrum. Notice the smooth interface between the labrum and the cartilage in this region. This is the supraspinatus tendon and muscle. The muscle has a somewhat horizontal orientation. This is the infraspinatus muscle, which has an oblique orientation, and the infraspinatus tendon inserting on the greater tuberosity. And this is the teres minor muscle and tendon. Sagittal oblique plane, fats press T2 and T1. Humeral head, biceps tendon within the bicipital groove. Rotator cuff, inserting on the greater tuberosity and lesser tuberosity. Here, subscapularis tendon. Here, supraspinatus tendon, infraspinatus tendon, and teres minor tendon, all of which can be followed to the myotendinous junction. Entering the joint and inserting at the supraglenoid tubercle. This is the coracoid process with the short head biceps and coracobrachialis. Here is the acromioclavicular joint. This is the region of the coracoclavicular ligaments. This is the glenoid labrum, seen on FOSS. Axial, plane, clavicle, and acromial process at the acromioclavicular joint. Note its alignment, lining up anteriorly and posteriorly. Supraspinatus muscle and tendon, coracoid process, posterior labrum, and teres minor tendon and muscle. The glenohumeral joint is the most mobile joint in the body. This is possible through a delicate balance between laxity and stability. The glenohumeral joint is described as a ball and socket joint. A deep socket provides stability, though greater constraint limits range of motion. The shoulder joint sacrifices depth and therefore joint constraint for greater mobility. In the shoulder, only 30% of the humeral head articulates with the glenoid at any time, and that contact area will vary throughout the motion arc. The glenoid fossa is also very shallow, only 2.5 millimeters in depth in the AP plane. Because of lack of bony constraint, it's often compared to as a golf ball on a tee. The bone does play a critical role in joint stability, but joint geometry is not enough to provide joint stability. The labrum increases the depth of the glenoid by 50%. Together with the glenohumeral ligaments and joint capsule, these structures help generate and maintain negative intra-articular pressure, which pulls the humeral head and glenoid together. The rotator cuff provides both active and passive stability, and the big muscles around the shoulder girdle provide additional muscle support. The kinetic chain is an engineering concept used to describe movement in the body as the transfer and summation of energy generated in the body segments and joints. In tennis, for instance, 50% of the total force in a tennis serve is generated by the legs and trunk. The scapula transmits this energy to the upper extremity. The shoulder not only has to transmit the energy, but also generate forces on its own. Forces which are ultimately transmitted to the elbow and wrist and then to the ball and racket. Athletes use their shoulders at high levels and often repeatedly, and that can cause rotator cuff pathology, which, like the rest of us, is a common cause of pain and dysfunction. Normal tendons are low signal on proton density sequences. With aging and overuse, the tendon undergoes degeneration, which we call tendinosis or tendinopathy. On MR imaging, the tendon increases in signal and can be enlarged. The degenerated tendon is weak, and continued injury can result in partial tears, which involve some but not all of the tendon fibers. This is an articular side partial tear. Coronal oblique and sagittal oblique images show discontinuity of the articular side tendon fibers, which spares the bursal side fibers. This partial tear involves the bursal side fibers but spares the articular side. If the tear goes from the articular to the bursal side, it is called a full thickness tear. Partial tendon tears come in a number of varieties. The pasta lesion, or partial articular supraspinatus tendon avulsion, involves the articular side of the tendon at its footprint. Delaminating tears cause horizontal splits within and between tendon fibers. Paint lesions, or partial articular-sided tears with interstitial extension, are articular-sided partial tears with tendon delamination. And concealed footprint tears are tears within the substance of the tendon, which don't extend to the articular or bursal side, and therefore can't be seen at arthroscopy or on MR arthrography. Let's look at some sport-specific injuries. The throwing motion is a highly complex movement that has been extensively studied. There are 6 phases, but we are going to focus on these phases where the shoulder is most active and injuries are most likely. During the cocking phase, lower extremity and core energy is transferred to the shoulder. Rotator cuff muscle activity peaks, generating power to move and stabilize the shoulder. At the end of the cocking phase, there is a rapid increase in elbow flexion. Shoulder external rotation and abduction reaches the maximum. During acceleration, the shoulder internally rotates, the elbow extends, and all the energy is transferred to the ball. This is where the greatest speed is generated. But it doesn't end here. After ball release, the shoulder muscles slow the arm. Compressive forces peak in the shoulder as the rotator cuff resists distractive forces on the arm. During the follow-through, the biceps muscle decelerates the elbow and the forearm. Let's take a closer look at the late cocking phase. The shoulder is at maximum external rotation and abduction. In this position, the articular surface of the posterior rotator cuff and posterior superior labrum are impinged between the greater tuberosity and the glenoid rim. This causes tears of the posterior superior labrum and articular side tears of the posterior rotator cuff. It's called internal impingement. It's manifest clinically as posterior shoulder pain and stiffness, and it's in this impingement position that we do our AREP imaging. The AREP view is done in the position of internal impingement. We add this sequence to the end of our MR arthrograms. The shoulder is abductor and externally rotated. The shoulder coil is swapped out for a flex coil, and axial oblique images are obtained. This results in images that look like this. They conveniently show the structures affected by internal impingement. This is an 18-year-old baseball pitcher with right shoulder pain for 2 months. These are MR arthrographic images in the coronal oblique and axial planes and in the AREP position. The T1 bright signal is intra-articular gadolinium, and we can see it insinuating into the articular side fibers of the rotator cuff at the supraspinatus infraspinatus junction. We also see reactive subcortical cysts in the humeral head at the site of impingement and a tear of the posterosuperior labrum. On the AREP view, we can see impingement of the rotator cuff and posterosuperior labrum between the humeral head and glenoid rim, as well as subtle articular side fraying of the tendon and tearing of the posterosuperior labrum. This is a 24-year-old man with shoulder pain and difficulty pitching. These are contiguous coronal oblique MR arthrographic images from front to back. Here is gadolinium insinuating into a tear along the base of the posterosuperior labrum and insinuating into the articular side fibers of the supraspinatus infraspinatus tendon. The key to pitching speed is external rotation in the cocking phase. The key to pitching speed is external rotation in the cocking phase. The key to greater pitching speed is greater external rotation. To achieve this, pitchers adaptively shift their humeral head center of rotation posterior-superiorly over time. The anterior capsule becomes tight. The greater tuberosity can now clear the glenoid rim and externally rotate further, and the pitcher is rewarded with faster pitches. Over time, these adaptive changes in the shoulder biomechanics can result in pathologic changes in the posterior joint, with remodeling and focal retroversion of the posterior glenoid, contracture and ossification of the posterior joint capsule called the Bennett lesion. Peel back of the biceps tendon, which goes from an anterior and horizontal orientation to a vertical and posterior orientation at the end of late cocking, results in torsion and can result in slap tears, tears of the biceps tendon and base of the superior labrum at their bony attachment. The changes in the posterior joint are related to excessive posterior joint loading. Adaptive remodeling of the posterior glenoid results in focal retroversion. Repetitive tensile loading of the posterior capsule causes capsular microtears and scarring. This may ossify. This is called a Bennett lesion and is not necessarily symptomatic. Pathologic changes in the posterior joint can also result in clinical loss of internal rotation, called glenohumeral internal rotational deficit, or GIRD, for which there are no reliable imaging findings. The spectrum of pathology in the overhead throwing athlete is nicely depicted on this MR arthrogram of this 16-year-old baseball player with shoulder pain. Coronal oblique fat suppressed T2 and fat suppressed T1 MR arthrographic images reveal articular side partial tear of the rotator cuff at the supraspinatus infraspinatus junction, which is undercut by gadolinium on the MR arthrographic images and by fluid on the T2 sequences. There is also a tear of the posterior superior glenoid labrum related to internal impingement. There is focal posterior glenoid remodeling with ossification of the posterior joint capsule seen on the axial and sagittal oblique images. This is due to excessive posterior joint overload. On the abducted and externally rotated view, we can see that the humeral head is minimally posteriorly positioned. You can see the anterior portion of the joint is a little bit wider than the posterior. This is due to subtle shift of the central rotation of the humeral head in this position. This is associated with tear of the posterior superior glenoid labrum and the undersurface of the rotator cuff. The labrum has an important role in glenohumeral stability. The labrum deepens the glenoid and increases the congruence of the glenohumeral joint. It helps maintain negative intra-articular pressure in the joint. It also serves as the attachment to the glenohumeral ligaments, importantly the inferior glenohumeral ligament, to the bone. The superior labrum and biceps tendon arise together and are firmly attached at the supraglenoid tubercle. The biceps tendon and labrum are low signal on proton density weighted sequences, and the superior labrum is normally triangular shaped. There is normally no or very small smooth fluid-filled cleft between the base of the superior labrum and subjacent cartilage. Slap tears, or superior labrum anterior to posterior tears, are tears of the superior labrum that can cause pain and instability. These are often the result of acute impaction or compression of the shoulder with the arm in forward flexion, or with repeated overhead activities that either place torsion or traction on the biceps labral complex, or impingement. Slap tears, or superior labrum anterior to posterior tears, are tears of the superior this normal appearance. Study the appearance of the different types of labral tears and the structures they involve, because that's more important than being able to type them. Here is a type 1 tear, which is the result of fraying of the free edge of the labrum. With type 2 tears, we have not only tear at the base of the labrum, but a tear that dissects into the glenoid attachment of the biceps tendon. Type 2 tears are more common in overweight athletes due to excessive torsion on the biceps labral complex, which peels back and detaches it from the bone. Type 3 lesions are bucket handle tears of the labral substance that don't involve the biceps anchor, and type 4 lesions are bucket handle tears that extend into the biceps tendon. This is a 30-year-old man with shoulder pain and instability after a basketball injury. Coronal, oblique, and axial images reveal hyperintense signal underlying the base of the posterior superior and posterior. In another case, contiguous coronal oblique images show increased signal within the interarticular biceps tendon due to a split tear contiguous with the tear at the base of the superior labrum, which propagates posteriorly. MR arthrography can sometimes increase the conspicuity of the labral tear by allowing injected contrast material to insinuate between the tear parts, but it isn't always necessary, especially if the tear is large enough. Here, coronal oblique fat suppressed T1 shows fluid undermining the base of the posterior superior labrum related to a tear. Coronal oblique fat suppressed T1 and axial fat suppressed T1 from the same patient shows gadolinium insinuating into the base of the torn labrum. The presence of a paralabral cyst is also an important clue that a labral tear is present. Here, sagittal oblique image shows another patient, paralabral cyst in the posterior superior quadrant on the sagittal oblique image. On the coronal oblique image, we can see the beginning of the posterior superior cyst and the fluid signal in the subjacent labrum. We can follow this signal into the biceps anchor. This is a 21-year-old college basketball player who presented with a sensation of weakness and heaviness in the arm while reaching over his head. Axial sequence reveals a tear in the posterior superior labrum and a cyst in the region of the spinal glenoid notch. Sagittal oblique sequence reveals the craniocaudal extent of this cyst, dissecting down the spinal glenoid notch, as well as increased signal in the infraspinatus muscle, which corresponded with clinical exam findings of infraspinatus atrophy. Paralabral cysts are often asymptomatic, but because of their location, can compress the suprascapular nerve. After it crosses the trapezius muscle, the suprascapular nerve passes through the suprascapular notch, where it innervates the supraspinatus muscle. It then descends down the spinal glenoid notch, where it innervates the infraspinatus muscle. The nerve can be compressed anywhere along its course. Paralabral cysts along the proximal course of the nerve in the suprascapular notch cause atrophy in both the supraspinatus and infraspinatus muscles. Cysts in the spinal glenoid notch will only affect the infraspinatus muscle. The suprascapular notch is also a potential site of nerve impingement in athletes, where the nerve passes under the superior transverse scapular ligament. Suprascapular neuropathy is a rare cause of pain, and because it's not always associated with a functional deficit, it can go undiagnosed or unnoticed. A systematic review in 2017 showed that overhead athletes are affected by suprascapular neuropathy at a greater rate than in the general population, and it's presumed due to nerve injury with repetitive overhead motion. For volleyball players, the serve and spike motions can repetitively place the nerve in traction. In these cases, we may only see the sequelae of denervation, with edema in the supraspinatus and infraspinatus muscles, but no mass effect or compression upon the suprascapular nerve. Swimmers are unique in that 90% of the driving force to propel the body through the water comes from the shoulders. An elite swimmer will perform tens of thousands of strokes per arm per week. It's no surprise that the shoulder is the most common reported area of injury in swimmers. Now, does this position look familiar? irritation of the subacromial subdeltoid bursa, which is squeezed between the rotator cuff and bony structures of the coracoacromial arch. These include a lateral downsloping acromial process, an inferiorly offset acromial process, anterior acromial osteophytes, and acromioclavicular joint osteophytes. But in someone in whom impingement is dynamic, extrinsic causes may not be evident, and only secondary signs, such as subacromial bursitis or rotator cuff pathology, may be present and indicative of subacromial impingement in the appropriate clinical setting. Let's switch gears and take a look at traumatic injuries of the shoulder. Shoulder dislocations are common and most often occur in the anterior direction. They're the result of an indirect injury to the shoulder, with the arm abducted, extended, and externally rotated, or as a result of backward fall and outstretched hand. Shoulder dislocations are after the humeral head is anteriorly dislocated, it becomes impacted on the anterior glenoid rim. This produces a fracture of the humeral head called a Virasack lesion, seen here on the axial and sagittal-oblique fat-suppressed fluid-sensitive sequences as a focal depression in the humeral head with marrow edema. The Virasack lesion is classically best seen on internal rotation views, but if it's more medial or posterior, it can also be seen on the axillary view. This is what it looks like on the 3D surface-rendered image from a CT, showing the linear depression along the posterior aspect of the humeral head, medial to the radial tuberosity, and the injury to the bone seen at arthroscopy. The posterior lateral humeral impaction injury is seen in almost all first-time dislocators, and as you can see in these different patients, the size and location can vary. When the humeral head dislocates anteriorly, it also injures the anteroinferior labrum and the anterior band of the inferior glenohumeral ligament. When these structures are avulsed from the glenoid rim, it's known as a Bankart lesion. It's seen in greater than 90% of shoulder dislocations. This is the typical MR appearance of the classic soft tissue Bankart lesion on the axial image. Avulsion of the anterior band of the inferior glenohumeral ligament from the glenoid attachment and the anteroinferior labrum. Anteroinferior labral injuries also come in other varieties. Sometimes an anterior dislocation results in a fracture of the anteroinferior glenoid rim, known as a bony Bankart lesion, which detaches a fragment of bone along with the anterior band of the inferior glenohumeral ligament and the anteroinferior labrum. Sometimes only the labrum separates from the cartilage. This is called a GLAD lesion, or glenoid labrum articular disruption. If the scapular periosteum is also stripped but not torn, a Perthes lesion develops, and if that torn labrum heals and scars along the anterior scapular neck, we have an ALPSA lesion, or anterior labral periosteal sleeve avulsion. Here again is the appearance of the classic Bankart lesion on the axial image and sagittal oblique image. The anteroinferior labrum is detached and anteriorly displaced from the glenoid rim. The scapular periosteum is disrupted. At arthroscopy, the torn labrum is easily lifted away from the glenoid rim by the probe. Soft tissue Bankart lesions such as this can be treated with soft tissue Bankart repairs, seen here in the last image with sutures securing the labrum to the glenoid rim. When you fracture the glenoid rim, you compromise one of the bony constraints. Bankart fractures vary in size, and the larger the lesion, the greater the bone loss, and the more likely it will be associated with recurrent instability if not treated. Glenoid bone loss is assessed using a diameter-based method. A best fit circle is drawn along the lower rounder portion of the glenoid. The diameter of the circle, as well as the anteroposterior length of the defect, is measured, and the percent bone loss is calculated by dividing the defect by the diameter of the circle multiplied by 100. It's generally accepted that bone loss greater than 25% should be treated with some form of glenoid augmentation, such as a Latarjet procedure, or iliac or allograft bone augmentation. Here's an example of a patient with a fairly large anteriorly displaced anteroinferior glenoid rim fracture seen on the 3D rendered CT image. In this case, the calculated glenoid bone loss is 26%. Therefore, this patient is indicated for a bone augmentation procedure. A Latarjet procedure places a block of the coracoid bone and its attached muscles along the anteroinferior glenoid rim to provide additional bone and soft tissue support. When you have both a Hill-Sachs lesion and a bony Bankart lesion, it is called bipolar bone loss. Who now dislocates after their initial injury? Studies tell us that the risk for recurrent instability following first-time dislocation depends on whether or not you participate in contact sports, if you have a job that requires using the upper extremity above chest height, your age, your gender, and the type of extent of bony injury. But is there an objective way to assess recurrence risk based on the type and extent of joint injury? This exam gives us a clue. This is an MR arthrogram on a 37-year-old man with recent shoulder portion of the glenoid surface. What if he were to further externally rotate his shoulder? Could this Hill-Sachs lesion catch the glenoid rim and cause a dislocation? A currently popular concept that studies this is called glenoid track. The glenoid track represents the normal contact zone between the humeral head and the glenoid when the arm is moved along the posterior range of motion. It's shown here as this pink zone along the posterior aspect of the humeral head. This contact area is reduced if there is glenoid bone loss. When a Hill-Sachs lesion is within this normal contact zone, it is considered to be an on-track lesion, and therefore unlikely to engage the glenoid and cause a recurrent dislocation. If a Hill-Sachs lesion extends medial to this normal contact zone, it is considered to be an off-track lesion, because just like a train derailing off a track, these lesions can engage the glenoid rim when the shoulder is abducted and externally rotated, and can cause the humeral head to dislocate. This is an important concept because it acknowledges the importance of the location of the Hill-Sachs lesion while taking into account the effect of the glenoid bone loss in the risk for recurrent instability. This is how we assess the Hill-Sachs lesion and glenoid track. Step 1 is to assess glenoid bone loss. This can be done on a sagittal oblique MR, CT, or 3D surface rendered image. Step 2 is to calculate the glenoid track. The glenoid track is calculated to be 0.83 times the width of the intact glenoid minus the width of the glenoid bone loss. In this case, the glenoid track is 0.83 times 35 minus 3, or 29 minus 3, or 26 millimeters. Step 3 is to measure the Hill-Sachs interval. The Hill-Sachs interval is the distance between the medial image, but it can be corroborated on the 3D surface rendered images. In this case, the Hill-Sachs interval is 25 millimeters. If the Hill-Sachs interval is less than the glenoid track, as in this case, the lesion is considered to be an on-track or non-engaging lesion. If the Hill-Sachs interval is greater than the glenoid track, the lesion is considered to be an off-track or potentially engaging lesion. Let's take a look at a real case. This is a 16-year-old woman who presents with recurrent instability. Her Hill-Sachs lesion is shallow and wide, but extends pretty medial, and there's very little glenoid bone loss. It doesn't seem like much. But take a look at where this Hill-Sachs lesion is when her shoulder is abducted and externally rotated, dangerously close to the anterior glenoid rim. It would not take very much more abduction to get that humeral edge to catch. So let's do an assessment. The glenoid track is 0.83 Knowledge of the degree of glenoid bone loss and whether the Hill-Sachs lesion is on or off track has been helpful in guiding the surgical management of these patients. Failure to address both the humeral and glenoid defects risks recurrent instability after surgery. When there is small or no glenoid defect and an on-track Hill-Sachs lesion, an arthroscopic Bankart repair is likely to be sufficient. If the glenoid defect is greater than 25%, and the Hill-Sachs lesion is on track, glenoid bone augmentation, such as the Latarjet procedure, is indicated. Off-track Hill-Sachs lesions are treated with remplissage. In a remplissage, the infraspinatus tendon and muscle is fixed to the base of the defect to fill it. This can be done arthroscopically and is often effective in preventing the humeral head from engaging as long as it is not a very large defect. Okay. Well, the inferior glenohumeral ligament is one of the most important anterior shoulder static stabilizers, and it's taught when the shoulder is abducted and externally rotated, which is the position of injury. As we've seen, the great majority of injuries to the inferior glenohumeral ligament have been on the glenoid side with Bankart lesions. However, injuries to the humeral insertion of the inferior glenohumeral ligament, called Hagel lesions, are just as important to identify and report. Humeral avulsions of the anterior band of the glenohumeral ligament, called Hagel lesions, can occur with or without a Bankart lesion, and the consequence of missing or not treating a Hagel lesion may be recurrent instability. Hagel lesions are notoriously difficult to diagnose on imaging. The classic finding is the J sign, seen here on the coronal oblique fluid-sensitive sequence, the result of the humeral avulsion of the anterior band of the glenohumeral ligament. Lastly, let's talk about the acromioclavicular joint. The clavicle connects the upper arm to the axial skeleton. The clavicle connects to the axial skeleton through its attachment to the sternum via the sternoclavicular joint and to the shoulder via the acromioclavicular joint. The acromioclavicular joint is a synovial joint, and though there is motion at this joint, static and dynamic stabilizers maintain the AC joint width to 8 millimeters and the corticoclavicular width to 13 millimeters. There are 4 acromioclavicular joint ligaments, superior and inferior, seen here on the coronal oblique image, and anterior and posterior, seen on the axial image. And these ligaments can't be separated from the AC joint capsule, which also provides static stability. The acromioclavicular joint ligaments provide horizontal stability to the joint. The corticoclavicular ligaments go from the coracoid process to the undersurface of the clavicle and provide vertical stability. There are 2 components, the conoid and trapezoid components, which can be seen on the coronal oblique and sagittal oblique sequences. The deltoid and trapezius muscles provide dynamic support and static support via the deltotrapezial fascia, which can be seen on the coronal oblique image. With more severe injuries, these muscles may be detached from the distal clavicle. Acromioclavicular joint injury is one of the most common reported shoulder injuries in professional football players. This most commonly occurs due to direct injury to the lateral shoulder with the arm abducted. But it can also be due to indirect trauma following fall and outstretched hand. On an interesting note, we're used to talking about elevation of the clavicle when we talk about acromioclavicular joint injuries. Droop down after it has lost its connection to the clavicle. This frontal radiograph of both AC joints shows it well. The clavicles are in line with each other. The right shoulder, however, is lower than the left because it is no longer suspended from the clavicle. This is a fun fact, but don't worry. For the rest of the discussion, we will continue to refer to the motion of the clavicle as elevation, as it has been historically described. The Rockwood classification is a well-known classification system for acromioclavicular joint injuries, and it predicts soft tissue injury based on plain radiographic findings. Keeping an eye on the position of the clavicle with respect to the acromial process and the distance between the coracoid and undersurface of the clavicle. Grade 1 injuries are joint sprains. The radiographs are normal. The AC joint is aligned in the coronal plane, and the acromioclavicular joint distance is normal, less than 8 millimeters. The corticoclavicular distance is also normal. and less than 13 millimeters. With grade 2 injuries, the joint can be widened. The clavicle is elevated but not above the acromial process. In this injury, the acromioclavicular joint capsule and ligaments are torn, but the corticoclavicular ligaments are only sprained or partially torn. When the clavicle is above the acromial cortex, the joint is dislocated, and the joint is vertically unstable. In this grade 3 injury, both the acromioclavicular and corticoclavicular ligaments are torn, and the corticoclavicular distance is increased, but not more than 25 millimeters. Here is what a grade 1 injury looks like on an MR. The superior ligament and joint capsule is torn, but the inferior ligament and capsule are intact. Next case, the acromioclavicular joint is widened, the corticoclavicular distance is increased, and the clavicle is elevated but not above the acromial cortex. This is a grade 2 injury. Coronal oblique MR image confirms complete tear of the acromioclavicular ligaments. Increased signal in the corticoclavicular ligaments is indicative of ligament sprain. Here, the AC joint is dislocated. The clavicle is above the acromial cortex, and the corticoclavicular distance is increased but not more than 25 millimeters. This is a grade 3 injury, and sagittal oblique image shows the torn acromioclavicular ligaments. Sagittal and coronal images show complete rupture of the corticoclavicular ligaments. The difference between a grade 3 and grade 5 injury is the corticoclavicular distance. In a grade 5 injury, the corticoclavicular distance is more than 25 millimeters. There is likely greater injury to the dynamic stabilizers, the deltoid and trapezius muscles. With grade 5 injuries, the distal clavicle is so elevated that it can tent the skin and soft tissues. Here, the coronal oblique and sagittal images confirm tear of the acromioclavicular and corticoclavicular ligaments. Here, another example of a grade 5 injury. We see disruption of the corticoclavicular and acromioclavicular ligaments on the coronal oblique and sagittal oblique sequences. We can also see that there's injury to the deltoid and trapezius muscles at their insertion on the distal clavicle. Type 4 and type 6 injuries are much less common. In the type 4 injury, the clavicle is driven posteriorly, and in the type 6 injury, the clavicle is driven inferiorly. Let's look at our last case. This is a 16 The MR confirms the torn acromioclavicular and corticoclavicular ligaments. Axial images, however, show that the clavicle is posteriorly displaced, almost a centimeter, with respect to the acromial process. Axillary radiographs of the shoulder also show the posteriorly displaced clavicle in this grade 4 acromioclavicular joint injury. In conclusion, shoulder pain is common in athletes and non-athletes alike. Today, we reviewed the most common overuse and traumatic injuries of the shoulder and how MR imaging plays a role in the diagnosis and management of these patients. Thank you.
Thank you so much, Dr. Catherine. This was wonderful and excellent. I mean, very comprehensive about a sports injury which we see in shoulder joint and how we can use effectively MR to categorize them. Thank you so much.
Thank you for having me this morning.
Yeah, so we have multiple questions in the chat box. So the first question what we have is, they say there are multiple slap tears described. Do you describe the findings or report types of slap in your reports routinely?
I don't, and that's why it's just important to note. It's important to note where the tear what portion of the superior labrum is involved and the associated structures that are involved. And that would include the biceps tendon, most importantly. But slap tears can also involve the glenohumeral ligaments, the superior middle glenohumeral ligaments. They can go all the way posteriorly to involve the posterior labrum. They can be circumferential. And though it was in vogue to talk and type the slap lesions 20 years ago, it's really not that popular nowadays. And I find that most orthopedic surgeons don't really know the types either. They know some of the common ones. The four that I mentioned, they seem to be fairly familiar with. But beyond the first four classified slap lesions, they don't know what a slap 7 is. They have to look it up. So I think the bottom line is that it's important to detect it and then delineate what structures are involved and describe that in the report. And the clinician can put those together and decide what kind of treatment is necessary.
Perfect. Thank you. So the second question is, they ask about the indication to do an MR orthography. In which cases do we do an MR orthography? Kind of a broad question, I guess.
Yeah, MR orthography, as I showed, it's really helpful in delineating labral tears. Although with advanced MR imaging systems and high field MR scanners, it's less necessary. Nonetheless, if you are worried about a labral tear in a young person in whom a labral tear would affect their management, MR orthography is usually helpful, especially also if you're dealing with equipment that's also not a little bit not as advanced because the image resolution isn't as good. And what the contrast does is that it helps to stem the joints so that the gadolinium can get in between tears, between the tear of the labrum and other structures to make them more conspicuous. So I would say anybody in whom you're worried about labral pathology, in whom the diagnosis of labral tear would make a difference. Labral tears are obviously very common as you age. So an older person, it may not be as important to find out if they have a labral tear, but that's something that your orthopedic surgeon will be able to communicate to you.
This
Okay.
is JP, may I interrupt just for a little bit? Because I think this is
Sure.
important for this question. So this the same question about the MR orthography. Our attendee asked about the able lesion or able position. Is it difficult to do that? Or if it's difficult, you have any trick or any tips to make it easier?
It is a difficult position, especially in somebody who's had a dislocation. But if you haven't had a dislocation, and really the reason why it's difficult in people who've had a dislocation is because they have apprehension in that position because they're about to dislocate potentially. So, I did show some dramatic images on people who had a dislocation, but most of the time we do the ABER imaging on people who are not dislocators, for instance. And we used to do it routinely on all patients who had an MR arthrogram. It's the very last sequence, and so you've done the whole MR exam, the routine MR exam with the shoulder coil, and then you take the shoulder coil out and you have to reposition them. If you give the patient a little time to readjust and shake their shoulder out in between the two studies, the two parts of the exam, that helps a little bit because they've been, cramped in the scanner for, I don't know, 10, 15 minutes. And then you position them in that ABER position and you place the coil around the shoulder in that way. You should be able to get decent patient compliance for doing that. I think the biggest challenge with ABER imaging is really interpreting the results because it presents the shoulder structures in a way that's unfamiliar. It's not like any of the other imaging sequences. So I think it just takes a little bit of time and it's a bit of a learning curve to figure out where you are in the shoulder. But to me, that's been the biggest challenge. I think doing the position really, it doesn't really take very long at all. Like another sequence is 2 to 3 minutes, so it's not a big deal. And the time to position the patient probably takes another 5 minutes. So you will add time to your exam.
Thank you.
Thank you so much. The next question is, in a suspected labral tear patient, you see the MR as normal. So then do you perform an MR orthography? Or when you have an indication like that, you perform an MR orthograph even before doing a routine sequence of MR?
Yeah, I mean, I usually, we can't order the exam ourselves. So if we do come up empty
Yeah.
after we do an exam, if it's an orthopedic surgeon, they usually know if they really want to pursue the diagnosis of a labral tear, they will send the patient back for an arthrogram. If they're not worried and they just want to make sure that there isn't a labral tear, then that's all you need to do. So it really depends on what the orthopedist wants to do with that information. If it's confirmatory for negative, then that's great. If they want to pursue it further, then you do an MR orthogram. Certainly will increase the conspicuity of those labral tears, which may not be evident on a routine study.
Thank you. All right. So next question is, could you explain more detail about Hill-Sachs interval on MR imaging?
Sure. So, I mean, unfortunately, it's not always clear where the rotator cuff inserts on the greater tuberosity on the axial images. But really, what you're trying to do is you're trying to determine the distance between the greater tuberosity to the medial edge of that Hill-Sachs. Because the most important thing to know is that the more medial that Hill-Sachs lesion extends, the more likely it's going to engage the glenoid rim when the shoulder is in that AREP position. So the distance, so you sort of have to kind of guess where the rotator cuff is going to insert on the greater tuberosity and measure from there to the medial edge of the Hill-Sachs. And unfortunately, there aren't really any great articles that say specifically you need to use this image. I think if you are able to give them an idea that this, without over measuring, if you're able to give them an idea that this is coming very close to being a lesion that can engage, that's helpful information that they can put together with their clinical exam, because when they're doing their exam, they may feel a great deal of apprehension when the patient goes into the AREP position on clinical exam to say, oh, I think this is probably going to be engaging. I hope that answers the question. I mean, I wish I had a better, I wish I had a better reference for it, and I may be able to find an article which shows it a little bit better, but you're basically trying to estimate the distance between the greater tuberosity and the medial edge of the Hill-Sachs.
Okay. Okay. Makes sense. Yes. Interesting. Oh, thank you. Thank you. And the next question is, what is your experience about MR imaging features in multidirectional instability?
So multidirectional instability can be due to a lot of things. In an older patient, they can have multidirectional instability because they have rotator cuff pathology. So it may not be labral at all. Being aware that so many structures play a role in glenohumeral stability. So if you're just looking for labral pathology and multidirectional instability, then you will find that you'll have, for instance, tears of the anterior labrum, anteroinferior labrum. You will also have tears of the posterior labrum. Multidirectional instability may also be related to the rotator interval joint capsule. So that can be patulous and cause instability. So there's a lot of, so I would say that if you have, if the history is multidirectional instability, you're looking at all the components of the shoulder that provide stability to strengthen your argument that you have multidirectional instability, and that would include looking at the labrum, the joint capsule, and the rotator cuff for starters.
Okay. Well, thank you so much. I guess that was our last question for this for today. Nat, do you have any questions for Dr. Catherine?
I do not. It's very nice lecture. Thank you so much. That's a lot of work on that talk.
Yeah, no, it's a lot of information on. Hopefully, if anyone has any questions, they can feel free to contact you, and maybe I can provide some references for anything that was unclear after the talk.
Thank you.
Thank you so much.
Thank you so much.
Thanks, Dr. Catherine, again for such an excellent lecture, with very good demonstration with all. Thank you so much for being here.
His baby.
Sorry about that.
All right. Thank you, Dr.
Thank you.
Petchprapa. Thank you.
Thank you.
Thank you. Have a good day. Bye-bye.
Have a good day. Bye-bye.
Bye-bye.
Thank you. Again, I just want to make a small announcement for all the attendees that the next week's session, we have sports injury MRI of knee joint by Dr. Felix Gonzalez. We'll see you next week, same time on a Sunday. Thank you so much.
Thank you, JP.
Thanks, Matt. Thank you, Josh.